Let us try to learn about this very big disease, one of the very big public health problem disease. And of course, to the clinicians, it's again a nightmare that how to treat hepatitis and because of the chronicity of hepatitis. Hepatitis, as we all know, it can be hepatitis A, B, C, D, E or F. Of course, F is one of the most rarest and F is only one which is usually, that's what we know right now, it's related with blood transfusion. If you talk about A to E, they all have perinatal mode of transmission. If you talk about the center three, that is the B, C, D, they essentially will also have a blood route of transmission. But if you talk about A and E, these are essentially having the fecal-oral mode of transmission. So please remember, all can have the perinatal mode of transmission. Let us dive into each of them and see what are the features that we need to remember for our exam from public health perspective. I think as you have seen that in all the previous modules, we have discussed in terms of the 6C features, SICSI. S stands for the source or the reservoir or the agent factors. We will also talk about the incubation period or any time periods which are related under the I heading. The C would stand for communicability factors, the period of communicability, mode of transmission, special points to remember S, and immunity prevention and control. Let us start with the first disease. We will talk about the hepatitis A. Hepatitis A. What is the source? The source and the reservoir. The source and the reservoir. The reservoir is of course humans. It is there in humans predominantly. The source is important from MCQ exam point of view. The source could be a case of hepatitis or it could be a subclinical case. I would like to bring your attention over here that the subclinical case, they are a big headache for hepatitis A because 3:1 for adults. 3 people will be subclinical cases or inapparent cases, or these are called as anicteric cases. Anicteric cases to the icteric cases. So in adults, you have 3:1 ratio. And do you know that in children, it is 12:1 ratio in kids. So that means in children, it is going to keep on spreading because 12, if there are 13 children, out of them 12 won't even tell you that we have got hepatitis A. If they're not telling you, so they will be able to transmit because it is a fecal-oral contamination mode of transmission. So essentially the maintenance of infection is by these subclinical cases, more so specifically talking about the children. So the maintenance of infection in the society, in the community is because of the subclinical cases or the anicteric cases which you don't even know they are happening in the community. That is the importance of the source. Next is the incubation period. You need to remember for hepatitis A, it is 10 to 50 days of incubation period. If you talk about the communicability is, we can categorize under 2 headings. We can talk about the modes of transmission or the period of communicability. Period of communicability can be an MCQ in the exam that it is communicable when it has an important feature that do you know that it is something like this. In the center, not in the center I'm writing, this is the onset of the sign and symptoms. That is mainly like what sign and symptom are we talking of? Of course, jaundice. So let us say at this junction, the jaundice starts, and do you know that the period of communicability is 2 weeks before the onset of jaundice and for approximately 1 week after the onset of jaundice. So that is a huge 3 weeks, that is approximately a month. The person might be shedding viruses and disseminating viruses, and more so the more dangerous part is the incubation period. So at this point, the person doesn't even know that they've got jaundice. Do you know that the maximum communicability is when the maximum communicability of hepatitis happens in the incubation period or in the early part of the disease? So that is a big headache again. So one is people don't tell. Even if they're telling, they've already disseminated the virus. That is the importance of the period of communicability. The mode of transmission, we all know it's a fecal-oral mode of transmission. It can also have a perinatal spread. It can also have a perinatal mode of transmission. In certain situations with the reservations, I'm writing with a star mark, that it can also have a parental mode of transmission and sexual route also. So sexual route can happen and a parental route, but still they do not form the major part of the mode of transmission, chain of transmission. The major chain of transmission is established by the fecal-oral transmission, that is from the stools, the virus, the flies, the food, the person, stool, flies, virus cycle is there, right? So that is about the SIC. Next, let us come and learn about the special features which you need to remember for your exam. The special features about this hepatitis A virus, point number 1, I'll tell you 4-5 things you need to die hard remember for your exam. The special feature number 1 is that this virus is the one of the few virus which is not killed with the normal chlorine levels. It is not killed, it is not affected with normal chlorine levels. With normal chlorine levels, the chlorine levels in the water should essentially be more than 1 part per million to have an effect. So normal chlorine levels are not affecting it. Second point, it is heat resistant. It is heat resistance till 60 degrees Celsius. So for more than 60 degrees Celsius, we might get the virus may be heat labile only after it reaches 60 degrees Celsius. Third is regarding the chemical disinfectant. If you talk about the chemical disinfectant, which is the disinfectant of choice, of course, that is there for most of the viruses or most of the infections as well. The chemical disinfectant is 0.5 to 1%. If you get one answer, please mark 1%. Sodium hypochlorite, that is the general disinfectant. Sodium hypochlorite solution, that is the disinfectant of choice. And last is about the disease. If I talk, the case fatality rate is less than 1% and 98% are supposed to recover. So usually we call it as a self-limiting disease. But the problem is the morbidity which is associated, the level of the jaundice which is associated, and in fact hepatitis A many times is maintained in the community and never reported to the public health system because everybody harbors the infection and very few would get the infection. Are you getting it? Everybody harbors the virus, but very few are going to manifest with the disease. Even if they manifest, it is a 98% recovery rule. So 98% recovery rule is there. So 98% are going to recover, less than 1% is going to have a case fatality rate. The next is I, that is the 6C features. We are talking of the immunity, the prevention and control strategies. Under immunity prevention control strategies, how are you going to prevent hepatitis at the first place? That is important because it's kind of a guerrilla warfare. See, tackling hepatitis and that also hepatitis A or soil transmitted helminthic infections or malaria or dengue on a community level, it's not about hitting a disease with a drug. In clinic, it is directly you give a drug, the patient gets fine. But over here, it's like a guerrilla warfare. You have to play with the mind of the community and you have to draft a policy which is going to be effective at the community level. So if you talk about hepatitis A, which is going to maintain in the infection in the society, you can have two approaches. We can kill or stop the reservoir control. Reservoir could be anyone, like it could be the case, it could be the carrier of hepatitis A, or we can also have the transmission control. Transmission control. What do you mean by the reservoir control? That means the reservoir has to be stopped. The reservoir could be the case or it could be you, it could be me. So we want to improve the sanitation, overall sanitation in the community. And that's the reason in STH also, soil transmitted helminthic infections also, you must have heard, we talked about the primary prevention, that is sanitation. We now in India have a 0.5%, that is the sanitation or the Swachhta cess. Also Swachh Bharat Abhiyan cess. We also have education cess. So that is to promote education, but we also have a sanitation cess in India when we pay taxes, right? So reservoir control by improving sanitation, by improving the disinfection strategies that we deploy when we are tackling with the patient of hepatitis. Next is how to stop the transmission control. The transmission can be improved by improved water supply. How will you improve the water supply, or what do you mean by better and safe water? We want that all the water should be chlorinated. So at least a chlorination level decent 0.7 to 8.8, 0.9 should be there. But chlorination is of course not an answer because just now I told you that the virus is not destroyed by the normal levels of chlorine. So what is the chlorination? It should be kept as more than 1 parts per million in the areas where the hepatitis A is known to occur. Cases of hepatitis A are known to occur. Also in those areas, the pH of the water can be kept as below 8.5 because that would stop decrease the spread of the hepatitis A virus. Talking about the immunity, that we also have a hepatitis A vaccine. The vaccine could be two vaccines. We can have a live attenuated vaccine. We can also have a killed vaccine. The live attenuated vaccine, nothing very special. It is a subcutaneous vaccine which is a single dose, and it is not found to be very effective, and it is not used very commonly. If you talk about the killed hepatitis A virus vaccine, it is a formaldehyde inactivated virus vaccine. It can be given to cases who are high risk, who are traveling to hepatitis A endemic area, who are laboratory professionals who are handling hepatitis viruses. So in those cases, we can give a killed virus vaccine to these people who are under high risk. So remember, for high risk only it is advocated. It is not to be given to the general public. It is given to age more than 1 year. It is given at the dose of 2 doses of hepatitis A killed vaccine can be taken, which are taken 6 to 12 months apart. The dose 1 and the dose 2 should be taken 6 to 12 months apart. It shouldn't be taken like together or between 1 month or 2 months. Usually we say that 2 doses of killed vaccine may give us a lifelong immunity. Lifelong immunity with the 2 doses of hepatitis A vaccine. Also, beyond this, we also have a hepatitis A immunoglobulin. This hepatitis A immunoglobulin is very effective. It is up to 90% effective if it is given within 14 days of exposure. So that was an MCQ also in one of your exams previously, that how much is the effectivity of hepatitis A immunoglobulin? 90% effective if given within 14 days. Hepatitis A immunoglobulin can be given along with the hepatitis A vaccine also. So it both can be given. They improve the efficacy and efficiency of protection to the patient. As far as the dosage of hepatitis A immunoglobulin is concerned, it is given at the dose of 0.05 to 0.1 ml per kg dose, and it is given as IM injection, and these can be combined and given for effective protection against hepatitis A. So now let us talk about hepatitis B, one of the major public health problems amongst all the hepatitis. So of course all the hepatitis are important to us, but hepatitis B takes the center stage. It is the focus. Why do I say it is the focus? Because do you know that what is the global prevalence of hepatitis B on this planet? 3.5% of the people suffer from hepatitis B all the time. Do you know that what is the prevalence of hepatitis B in India? It ranges from 5 to 7%. There are areas which I even know which have 11 to 12% prevalence of hepatitis B. Do you also know that hepatitis B is a public health problem because 5 to 15% of hepatitis B cases might be associated with HIV, which is again a big public health problem, or with hepatitis C virus, which is a chronic hepatitis. Do you also know that hepatitis B virus increases the chance of hepatocellular cancer? It also increases the chance of cirrhosis. Of course, all said and done, cirrhosis would be major problem with the chronic type of hepatitis, but over here also it can occur in hepatitis B as well. So this makes hepatitis B as a focus point for all the hepatitis under the National Hepatitis Control Program. So what are the 6C features? As we have already talked about the 6C features, S stands for the source or the reservoir. The reservoir of all the hepatitis, in fact, would be humans. We harbor the infection. Also, specifically talking about hepatitis B, this reservoir could also be a chronic carrier. I'm not saying that chronic carrier are one of the biggest things in hepatitis B, but of course, they are the major source. They are the major people who are maintaining the infection, and that is what is the source, right? When do you call a carrier as a chronic carrier in hepatitis B? Please remember that a person who harbors hepatitis S antigen for more than 6 months will be labeled as a chronic carrier stage in hepatitis B. So the most important, again, that same story, the most important could be a case. The source of infection could be a case, or a carrier, case or a carrier. And carriers are, of course, one of the very important, either in hepatitis A or in hepatitis B. The carriers or the subclinical cases, they form the major chunk of people who are maintaining and spreading the infections. If you talk about the incubation period of hepatitis B ranges from 30 days to 180 days. So I've just remembered that in hepatitis B, the chronic carrier is for 6 months and the incubation period is also ranging from 1 to 6 months. That's how it just made it easy for me to remember that the chronic carrier stage is 6 months, the incubation period is also 6 months. If you talk about the C, 6C, that is the period of communicability or the modes of transmission. Now, the period of communicability is nothing very special till the time HBs is present in the blood. Till the time person is having HBs antigen positivity in the blood, till the time HBs positivity is there in the blood, till that time the period will be, the person will be communicable. What is the mode of transmission? The mode of transmission in hepatitis A was pretty easy. It was the fecal-oral. Over here, the blood route, or we call it as a parenteral mode of transmission, is most common. Although we can also have sexual mode of transmission, we can also have through body fluids, except the blood, of course, right? Other body fluids like body secretions, we should write down, like saliva. So these all may be related for the mode of transmission, but of course, which one is the main? If you get an MCQ, the main mode of transmission is a blood route or a parenteral route. Coming to some of the special features which you need to remember for your exam. Special features are: this virus is a heat labile virus, and the disinfectant of choice, DFOC. I'm not writing the drug of choice. The disinfectant of choice is same answer, sodium hypochlorite. Hypochlorite in what percentage? 0.5 to 1%. Sodium hypochlorite is used for hepatitis B virus disinfection. Coming to the next point about the IPC, that is the immunity. We'll talk about the immunity, the prevention modality, and the control modality. So immunity is important. Couple of times they ask you MCQs on immunity or the status of the vaccines in hepatitis B. You have two types of things. We can give a passive immunization or an active immunization. We can give HBIG. We do have an hepatitis B immunoglobulin, right? You can give a hepatitis B immunoglobulin. This is given at the dose of 0.05 to 0.07 ml per kg body weight. It has to be given in 2 doses, which is 30 days or 1 month apart. This is given as 2 doses, 30 days, 1 month apart. It can be given in case of known exposure, within 6 hours, but not later than 48 hours. It is best given within 6 hours or as soon as possible, not later than 48 hours. We can also have an active immunization, very frequently asked MCQ, active immunization for hepatitis B. You can give hepatitis B virus vaccine, which is a recombinant virus vaccine. It's a recombinant virus vaccine. It's a recombinant virus vaccine which can be given to children, and it can also be given to the adults. In children, we give it when we give it at a birth level, and then we are going to give it at 6, 10 and 14 weeks. 6, 10 and 14 weeks. So how many doses we are giving? We are giving 4 doses of hepatitis B vaccine. Birth dose has to be given within 24 hours. If given within 24 hours, that's fine. We give 4 doses. Otherwise, you leave off the birth dose. At least you give 6, 10 and 14. Hepatitis B, under the national immunization schedule, we are giving for all children till age of 1 year. Once you start hepatitis B virus vaccine at 9 months, at 10 months, in case the child was unimmunized, then we are supposed to complete the immunization dose under the national immunization program. It is given at the rate of 0.5 ml intramuscular injection in the anterolateral thigh. Usually we say that it is the left thigh, right? Next is about the adults. What is the dose of hepatitis B virus vaccine in the adults? It is 0 month, 1 month and 6 months. We are giving 3 doses. Usually it is given in the dose of 1 ml intramuscular injection. 1 ml intramuscular injection on day 0. Then after 1 month and then after 6 months. to all adults who are specifically high risk in all high risk cases. In all high risk cases. Another MCQ that you would like to remember over here, that since I have written it's a recombinant virus vaccine, do you think we can give to pregnant females in case we know there is an accidental exposure? Of course, this vaccine is safe in pregnancy. So of course, under the national program, we are not giving to all pregnant females, but in case there is a known exposure to a pregnant female from hepatitis B, any exposed person or hepatitis B known case, in those cases, can this virus vaccine be given? Answer is yes, we can give this virus vaccine. Next is a couple of times you get this question upon the accidental exposure to hepatitis. In case of accidental exposure to hepatitis, what are the steps we're going to take? You already know, and we have told you that in case of all cases of accidental exposure, we will give the hepatitis B immunoglobulin. So in case we are giving hepatitis B immunoglobulin, alongside we will also take these blood sample for hepatitis B surface antigen antibody. Antibody testing will be done. Antibody testing has to be done towards the hepatitis B surface antigen. So once you check for the antibody, based on that we will take the further action. But all said and done, please remember that after hepatitis B immunoglobulin, we will give the hepatitis B vaccine also. A lot of times I get this question, especially on social media, that can we give hepatitis B immunoglobulin and vaccine together? So please remember that hepatitis B immunoglobulin and vaccine, can it be given together, the hepatitis B vaccine? Answer is yes, it can be given. Do you know that any immunoglobulin and the vaccine can be given together specifically in 4 diseases, that is diphtheria, rabies, tetanus and hepatitis. Out of hepatitis A also, and hepatitis A and B, but more importantly you need to remember hepatitis B. So in those cases we can combine the hepatitis A or the B viral vaccine and the hepatitis B immunoglobulin. So please remember that hepatitis B immunoglobulin will be given within 6 hours, not later than 48 hours, and hepatitis B vaccine is initiated at the same time. You already know 0 month, 1 month and 6 months hepatitis B immunoglobulin within 6 hours to be given. Please also note that this can be an MCQ, that in what cases we are not going to give the hepatitis B vaccine. Hepatitis B vaccine will not be given in what cases? In cases where the HBs antibody, in case the HBs antibody level is more than 10 milli-international units per ml, then the HBV vaccine is not required. Or if the victim is a known case, of hepatitis B surface antigen positivity. So if the person is already having a hepatitis B surface antigen positive, in those cases you don't need to give a hepatitis B virus vaccine. Invariably it's not going to have the immunity protection, and in case the person already has the antibody level of more than 10. So that's the reason we do the antibody testing at the first level. Can it be given as co-administration? Answer is yes. Hepatitis B, is it safe in pregnancy? Answer is yes. These are a couple of MCQs that you usually get on hepatitis B from the infection, immunization, prevention and control strategy. So still on the hepatitis B, now let us talk about the prevention aspect. As far as the prevention and the public health policy and the National Hepatitis Control Program is there, in India, first is categorization of the areas you should know. So first is categorization of the areas. If the hepatitis B prevalence, hepatitis B prevalence of hepatitis is less than 2% in the area, 2 to 4%, 5 to 7%, more than 8%. If it is less than 2%, it is called as a low risk area. If it is 2 to 4%, it is called as a intermediate low risk area. If it is 5 to 7%, it is again called as intermediate risk, but this intermediate is a high risk area, intermediate high risk area, or sometimes we may land up into a more than 8% area, that is called as a high risk area for hepatitis. So based on this, the national health policies will be there, and based on this, you will have the prevention and control strategies under the hepatitis control. Most of the parts of the country are in 5 to 7 range, specifically talking about the urban sector. We do have some areas which are less than 2% prevalence, and of course we do have some red areas which are more than 8%. But in general, if you get a question 5 to 7% is what is the overall national prevalence of hepatitis B, even as per the NFHS 4 survey system. Next is talking about hepatitis B prevention and control on global level. So we have a 5C strategy. What is this next MCQ? This is 5C strategy devised by the WHO. So what are the 5 C's? That we should have hepatitis C budgeting and implementation and monitoring based on 5 C's. So we should always take the consent of a person. Second is there should be confidentiality of the cases. Third is correctness of diagnosis. That means the better tests and investigation should be used. Fourth is counseling, and last is connections, more connections and more implementation resources, so that you are able to tackle hepatitis B on a bigger scale, connections. So these are your 5 C's, which are the WHO 5C strategy. So you can be asked MCQ on this, which of the following are the C's, which are not the C's. So you just need to remember the names. Next is another MCQ, that on the global WHO strategy, there is a global health strategy devised in year 2016 till 2021. So in this, what are the targets? The targets by the WHO Global Health Strategy is to decrease hepatitis B by 90% by year 2030. Also to decrease the deaths or mortality due to hepatitis B by 65% by year 2030. So there are two objectives under this program, under the Global Health Strategy. You want to decrease the caseload of hepatitis B to be decreased by 90% and deaths to be decreased by 65%. And based on these targets, next is what are the strategies under this program. So the strategies under this program could be, again, we have already talked on these strategies, that is to promote hepatitis B vaccine. So minimum 3-dose vaccine should be there in all children. That is what is intensified mission Indradhanush, where you want to have 100% vaccine coverage. Second is prevention of mother to child transmission. Third is harm reduction. Harm reduction in what category? In people who are high risk. Example is intravenous drug abusers. Example is male to male, transgenders. To have harm reduction in these people, and safe blood practices, blood transfusions and all these things, and use of syringes in intravenous drug abusers in high risk cases. So mother to child transmission, harm reduction, hepatitis B virus vaccine, and early diagnosis and prompt treatment. So this is what is important from a public health perspective regarding the global health strategy devised in year 2016 till 2021. So regarding prevention, you need to remember the 3 things. We talked about the WHO 5C approach. We also talked about the WHO global health strategy. And third thing you need to remember is the categorization of the areas based on prevalence in India. So these are the 3 things you need to remember from public health perspective for control of hepatitis. Others were like you should know about the vaccines in hepatitis, and very importantly you should know what to do in the post-exposure prophylaxis. Do we give hepatitis B immunoglobulin and vaccine together? Yes, we do give them together. So with that, many things about hepatitis have been covered. Let us move on to the next hepatitis C virus. Next is, let us talk about hepatitis C. Hepatitis C, do you think it's a public health problem in India? Yes, indeed, it is a public health problem. The prevalence of hepatitis C in India is 0.5 to 1.5%. So it's not as big as hepatitis B, but it is a decent public health problem. Talking about the sexy features, SICSI. The source, reservoir is same in all the hepatitis, right? It's a human. The source could be a clinical case, or we can have a subclinical case, or the person who's inapparent or anicteric or not showing signs and symptoms of hepatitis C. MCQ is who's the major one? The major one is subclinical case. Now that is again a big headache, that in hepatitis C, do you know that 80 to 90% of all the cases are subclinical? So that means they are going to keep on spreading hepatitis C in the community. So that same problem like hepatitis A and hepatitis B, of course on a much bigger scale, because 80-90% are having infection and the pathogenesis in the body, but just that they are not able to show it. It's a subclinical infection, but they will keep on persisting. So try understanding the basic factors which are there in HCV. So any patient who gets hepatitis C, do you know that out of them 15 to 45% will automatically clear the infection? They will be all clear. There will be okay in some time. It is self-limiting. Do you know that roughly 55 to how much? 85? So approximately 55 to 85% will land up into chronicity. That is what is the big issue. So chronic hepatitis C will be 80%, 70% of all the hepatitis C cases. I agree that many are will all clear, they will get healed themselves, but 55 to 80% are going to land up into chronicity. Out of this chronicity, some will be progressive, some will be persistent. So you can have a persistent chronic stage or you can have a progressive chronic stage. The persistent chronic stage will be 70 to 80% out of this. So 70 to 80% will be showing persistent chronic stage. That is okay. But 15-30% are going to land up into a progressive stage. The progressive may land up into cirrhosis. That is what is the bad thing about hepatitis C. And sometimes approximately 5 to 6% may land up into a hepatocellular cancer. That is what is the most troubling feature in case of hepatitis, that 5-6% are going to land up into hepatitis C, hepatocellular cancers. Some mostly will land up into cirrhosis as well because of the progressiveness of this disease. And of course, many cases who are landing into progressive features, of hepatitis C, they will also be associated with HIV positivity and other co-infections. So that makes this whole system as a big public health problem, because just imagine if 1% of the whole country is suffering from hepatitis C, you will have lakhs of cases of hepatitis C and cirrhosis, which the system will not be able to manage. That's the reason you should have a prevention modality for hepatitis C much in place. So anyways, for your MCQs, you need to remember that subclinical cases are a major havoc and they are causing this 80 to 90% of the spread of transmission. And you know that from hepatitis C, important features that approximately how much will land up into the progressive stage. Can you imagine that 1/3 to 1/3 will land up into chronic stage? So that is what is bad. Next is about the incubation period. The incubation period ranges from approximately 2 weeks. It could land up into 6 months. So it's something from the hepatitis A and the hepatitis B. Both the incubation periods are combined, the lower part of hepatitis A and the upper part of the hepatitis B. Only if you can just correlate. That's how I have remembered about the incubation period of hepatitis C. If you talk about the communicability factors, the period of communicability could be another potential MCQ for you, because that is important from the public health perspective as well. So the period of communicability in hepatitis C, let us say that this phase, the onset of sign and symptom. With sign and symptom, we are talking of all the anorexia and malaise and the hepatitis C features like jaundice and all these things. So let us say that on this day, the clinical features are starting. So when is the patient more infectious? Please remember, the patient is most infectious. Again, same problem in the incubation phase. It has the maximum communicability. So what is the time? It is 1 week or 7 days before the onset of symptoms. The patient is most communicable. What is the mode of transmission? The mode of transmission could be predominantly a blood route transfusion. Blood mode transmission, it can be associated with transfusions, it can be associated with intravenous drug abuses, it can be associated with organ transplants as well. Very important in India is about organ transplants and hepatitis C. Of course, with blood, it can also be perinatal. So that is also one of a major problem of the mode of transmission. Talking about these special features which you need to remember, 2 special features you would like to remember for your exam. One, that it causes very high amount of hepatocellular cancers, and cirrhosis. How much approximately cirrhosis? 1/4 to 1/3 people will land up into cirrhosis. What is the most common cause of cirrhosis in India? Again, it is hepatitis C virus only, because C is very commonly linked with cirrhosis, and most of the cirrhosis cases or the hepatocellular cancer cases would be because of the chronicity of the hepatitis C virus. Next is special features about the diagnosis is important for you to remember, for you to know that how do we diagnose hepatitis C? The only diagnostic modality is RT-PCR. That is the gold standard we have. Another way to diagnose hepatitis C is the HCV, RIBA we do. RIBA. What is RIBA? Recombinant immunoblot assay. RIBA is a recombinant immunoblot assay. So we can either do a RIBA, which is not, of course, one of the gold standard. The gold standard would be a RT-PCR. Last is about the I section. I section is lowest in hepatitis C. I don't have anything to say because we don't have anything to measure on a preventive aspect. We don't have the immunity or the prevention or the control. Yes, for the control, you all know that the best we can do is give them DAA. What is DAA? Directly acting antivirals. So we can have DAA therapy in hepatitis C to stop the progression from the acute phases to the chronic phases. And the prevention modality will be only one, that is to improve sanitation, which of course does not help much, but more importantly, we want to promote a safe blood supply, or safe blood practices is what is the most important thing feature in hepatitis C. Next is, let us talk about hepatitis E. Hepatitis E is essentially a non-A and a non-B virus. It's a RNA virus. Hepatitis E, if you talk, in India, the most common type of hepatitis E which is prevalent is a genotype 1. Genotype 1, which is hepatitis E genotype 1. Hepatitis E, 2-3 things you need to remember about the source. Source, you already know that we can have clinical cases and asymptomatic cases, and which is more common for maintenance of infection. For most of the hepatitis, this is happening, that asymptomatic cases are much more than the clinical cases, and therefore all types of hepatitis will show iceberg phenomena, and that's the reason there are many times the maintenance of infection in the community. Regarding the incubation period, it ranges from 3 weeks till 8 weeks. Roughly, it is said that 30 to 40 days is the average incubation period, 30 to 40 days. Most of the cases are asymptomatic. If you talk about the period of communicability, it's again more communicable during incubation period. More communicable during incubation period, and the mode of transmission is predominantly a feco-oral mode. It is a waterborne, more predominantly a waterborne. It can be foodborne as well. So if you talk about one out of water and food, it is more seen with more waterborne infection compared to the foodborne infection. The special feature which you need to remember for hepatitis E is the severity of hepatitis E, which will happen in pregnancy. So most of the cases are asymptomatic. It is again a self-limiting disease in most of the adults. But in case of pregnant females, it may lead to a very fulminant hepatitis. We don't have a major treatment for that, and the diagnosis of hepatitis E is by IgM or the IgG anti-HEV antibody. The treatment we do not have, it is all symptomatic treatment. So what is the infection immunity prevention and control strategies? It is only to improve the water quality in the area. Right? So only to improve the water quality. So with that, we finish most of your questions on prevention control aspect of hepatitis and their epidemiological determinants which are required for your MCQ exams.